Good morning, Emery. I see a slide that looks like a title slide without a title. I don't know if, I think there was one on the first one we saw. But maybe we can just get started. I know you all are busy people. I don't know if maybe we want to do just a quick introduction. I'll introduce myself. I'm Elizabeth Perez. I usually sit in Brooklyn on the third floor, and the general counsel at Cases. I also wear another hat, and that is as compliance officer at Cases, which means that is one of my jobs to have to make sure that Cases is working to and committed to and working on its compliance obligations. And we wanted to take this time to go over just a couple different compliance documentation issues that were identified as part of a review, a proactive review. So nobody's in trouble, or the OMEG is not knocking on our door, but we want to get these things right, and they're important to get right. So the few things that we're going to cover are adding the diagnosis to progress notes, and entering the actual start and end time to service to progress notes, the documentation, not just the scheduled default for a visit. And just to take a step back, those are not the only two parts of compliance, documentation compliance that are out there that you all are living with, that we all are living with. Those are a couple of things that just came up as sort of common issues that we want to address across the board. And this is not the case for everybody. This is not the case for all providers, but it's something common enough that we want to make sure you have the tools and the information and the support to be able to get this right, because they're easy wins for us in terms of compliance documentation. And just this is important to Cases. This is really important to Cases, both because we are committed to doing things the way they need to be done, but also the stick of this is that the Office of the Medicaid Inspector General in New York State can and does regularly do audits of organizations who bill Medicaid practices. So they'll come in and look and nitpick basically a selection of progress notes and say this did or did not support the service for which we were billed and for which we paid you. So it's part of a bigger compliance obligation to OMEG, and it's part of a bigger, here we go, yes. Federal and state law, so the Office of the Medicaid Inspector General is in New York, and the Office of the Inspector General for the federal government both have oversight of healthcare dollars, how they're spent, where they go. How do we know that those healthcare dollars are spent on things that are supposed to be spent on? This is $1 billion industry, so it's something that there are a lot of resources applied to in terms of getting this right. And just because we're a nonprofit organization doing amazing work doesn't mean that we have, that we can skirt by all the documentation requirements that that OMH and Medicaid OMEG put before us. So we're going to go over a couple of those things today and make sure that you have what you need, give you a chance to ask questions, hopefully, and know that this is not the only thing we're going to cover as part of our compliance program at Cases. There are other topics and other documentation requirements we want to go over. And again, these are just sort of things that we think we can get right now and that we know that we can improve on. So any other questions? I guess I didn't leave any time for anybody else to introduce themselves, so apologies for that. I just jumped right in. Nice to see you. And most of you are in a little box on my screen, and I don't get to see you in person. I'm sorry for that. But if you ever have questions about compliance, there is a bigger compliance training for Cases generally. You guys are all in a particular place at Cases where you really are deeply connected to the compliance requirements and as billable providers. But you could always come to me with questions if they arise going forward, or even we will have a chance hopefully for a couple of minutes at the end of this training.
Great, so I think I'm going to do the next piece. And good morning, everyone. I'm Anne-Marie. I'm the Chief Impact Officer at Cases, and within my team is quality improvement, and we're always in CareLogic doing monitoring of documentation to ensure both medical necessity, ongoing medical need, which is called utilization review, as well as adherence to the standards of care. So as Elizabeth had previously mentioned, there are many components to documentation, the progress notes that therapists, psychiatrists, nurses are writing in terms of the delivery of services. But this morning, we're only going to concentrate on two. We will come back to the others, but this is about the launch and expectations that need to start happening tomorrow for everyone sort of across the board to ensure that we are in compliance with a medical billing necessity related to Medicaid, Medicare, as well, and our private sort of health insurance, our commercial health insurance. So we're going to look at the two bolded areas on the charts, but we did want to reflect that there are many components to accurate and appropriate documentation, both in terms of demonstrating that a service was delivered, demonstrating someone's progress or lack of progress in treatment for the need for ongoing treatment. So in terms of medical necessity, that's a basic requirement of Medicaid. We have to confirm that someone has a medical need, and for us, a mental health need that warrants their admission to our clinic, as well as ongoing treatment within our clinic. And I'm going to sort of talk about how that is established for us in documentation and who is guiding and has overall responsibility for treatment based on the scope of services for the different licensed staff that we have within the clinic. The second component that we are going to look at this morning, and Olu is actually going to demonstrate for us, is a requirement around the documentation, in order to be established as being complete and concise, needs to have the accurate time that the service was delivered. And so we all know the scheduled times, and our scheduling is really based on the hour, half an hour, or every 15 minutes maybe. But Medicaid, for us to be able to bill, to attest that this service happened at this time, it's going to be really important that we have the accurate time. And so client may be scheduled to come at 2 o'clock, they come at 2:07. You started the session at 2:08, the accurate time, 2:08, needs to be in the documentation in order for us to bill according to the standards for Medicaid, Medicare, and the Office of Mental Health, and all of our oversight and governance, as well as for cases ourselves to have a true reflection. And this is for sort of all documentation. And I know that Billy and leadership at the clinic has been sharing that there were shifts in terms of some of the minimal time required for services, even though it may be a 30-minute session or a 45-minute session. Some of those regulations have been changed, and we're able to sort of benefit from them. But in order to, again, establish that documentation is accurate, we must have the real time in which you were meeting with a client. So first of all, I'm going to talk about medical necessity, which is for us is established by someone having a diagnosis, a mental health diagnosis that confirms they're in need of services at the Nathaniel Clinic. And so when we think about a medical diagnosis, and we know that clients come in, they may, there are some exceptions to this, like a client may come in and not be admitted to our clinic and receive a crisis service. And the regulations do allow us to bill for that service, even though there may be no attached diagnosis. But if a client is admitted to the clinic, our process and the required process that that's required by Medicaid and Medicare is that the clinic is the treatment is completed under the authority. Sorry, my phone is going up before I turned it off. It's the treatment is completed under the auspices and the authority of either a psychiatrist or a psychiatric nurse practitioner. And so we do know that LCSWs within their scope can independently diagnose. We know that recently within the scope that New York State has grandfathered in licensed mental health counselors and licensed master social workers. But in terms of Medicaid billing, there are just a few groups of folks, of providers who can diagnose independently and in which we are billing for those services. And those are psychiatrists, psychiatric nurse practitioners, and also LCSWs. So in practical terms, what that means is that we must, and you all must, in terms of your documentation for progress notes, be selecting the diagnosis that has been rendered by a psychiatrist or a psychiatric nurse practitioner. And so that really means that if a client is admitted to the clinic and they haven't seen a psychiatrist or psychiatric nurse practitioner as yet, it's essential that that happens. I know that we have seen some documentation where people haven't got to, they've been getting psychotherapy for a number of weeks and they haven't got to the psychiatrist. And so for us, it's just really critical that happens, because the treatment is being provided under the auspices of the psychiatrist or the psychiatric nurse practitioner. For clients who are receiving psychotherapy only services, Billy has shared with us that the procedure at our clinic is that the treatment plan is going to be signed by a psychiatrist. I believe Dr. Chanda does that as our medical director. And so it's really important that there is a treatment plan that is signed by the psychiatrist, which is then confirming, or psychiatric nurse practitioner, which is then confirming that the psychiatrist agrees with the diagnosis that has been rendered, and then we are able to sort of bill for services. So now we're going to switch over to the real-time in sessions, and Olu is actually going to share her screen. It's going to take us through a demonstration, and happy to take any questions at the end as it relates to who are we providing treatment under, which diagnosis must we use on our documentation.
Hello, everyone. My name is Olu. Can everyone see my screen?
Yes.
Oh, okay. Okay, so I'm just going to demonstrate on how to actually enter the actual time that you saw the client. I'm going to use the sandbox, as you can see. So this is a test client, okay? And this is my schedule for today, okay? So for this client, the appointment time says 9 to 9:45. So as soon as you're done seeing the client, you need to start us the appointment, okay? To start us the appointment, you will click on none over here. Okay, so this will bring you into the client activity status page. To keep the appointment, you would select kept over here. So selecting kept would initiate these other fields. This is where the time from and the time to, this is where you would enter the actual time, okay? On this page over here, this time, the start time and the end time defaults to the time on your schedule, but you're meant to go in and change this and put the actual time that you saw the client. So let's say this client came in at 9:07. I would change this to 9:07, and the end time will be the end time that you ended the session with the client, okay? So I can just gonna put like a random time. I could put 9:47, for instance, okay? So this is a required field, the time from and time to, so this is required. Again, when you get on this page, it defaults to the time on your schedule, but you're required to change this to the actual time that you saw the client. When you're done entering this information, you would click submit and continue to document. Okay, so this will take you into your documentation, or all this process. So you would complete this, then eventually sign your notes, and that's it. Okay. I'm going to go back to my schedule again and mention one last thing. you can come back into your schedule, click on kept, and you can make changes to this time at any point in time. Let's say you like to write your note after after the client has left and everything, you can still come back here and make changes to this. Okay. The most important thing is you need to make sure you're putting the actual start and the end time. Okay. And that's it. Thank you.
Dr. Chandra, you have your hand raised.
Yes, thank you, Olu, and thank you, Anne-Marie and Elizabeth. My question is, the start and the end time will be just patients face-to-face encounter, or it will include the time spent in writing notes too?
Yeah. It's the patient face-to-face encounter is the requirement, is the standard.
Okay, so it won't include the time spent in things other than that. For example, sending medication or reviewing their diagnosis or writing their notes. Okay, thank you.
You're welcome.
I have a quick question. When it comes to if a client's like 10 minutes late and we see them at 9:10 and we're supposed to end at 9:45 and we have another 9:45 session, is there a minimum time face-to-face for Medicaid billing that we need to adhere to? For example, I think it's for Medicare, I know it's 37 minutes to like 49 minutes or something is a 45-minute session, something like that.
Yes, and we can ensure that all those times are sent around to everyone, so everyone can see that there were changes, and there are, say, like a 30-minute session as an example. Don't quote me on this. The minimum time range for that could be 60 minutes to 30 minutes, and so we'll ensure that all of those times for all of those services are sent around. What you will also have to ensure is that you then also in your schedule select the correct documentation. So say you were scheduled for a 45-minute session with a client, but actually they arrived late, and you can only meet the standard for the minimum 30-minute session, then you're gonna have to ensure that you go into your schedule, select the documentation that's attached to the 30-minute session, put in the real times, and then proceed as normal as as you always do.
Thank you. I know that for us, if there is say a client comes late and I need to do a 15-minute session as opposed to a 30, the note is different. So in the past, I have gone back and actually reformatted it to a short progress note. If I can only meet 15 minutes, does that continue to be accurate? Okay.
Yes, and we can confirm that as well, because we also do know that for psychiatrists and psychiatric nurse practitioners, we're sometimes using E&M codes, and it's about the complexity of the different factors that you are also engaged in, and so we can ensure that, and Rebecca's on this, that Rebecca, maybe we're sort of doing refreshers for everyone to ensure that we are in full compliance.
Thank you.
Olga had raised her hand. I can see Olga.
Hi. Sorry if there's background noise. When you had mentioned that the psychiatric nurse practitioner is required to confirm a diagnosis, does that mean that even if someone is doing only psychotherapy, we still have to refer them for a psych eval, or is it just that they need to sign the treatment plan?
I think it's that they need to have an initial assessment as well. Yeah, because the only folks who can independently make that assessment is an LCSW. A licensed mental health counselor or a licensed master social worker is not able to make that determination. That's New York State standards, that's Medicaid standards. And we know that licensed mental health counselors and licensed master socials are also not Medicare providers as well.
Okay, thank you.
Olu, did you want to share about the notes that will be ready and when they will be ready for the diagnosis?
Yeah, sure. Actually, all the notes that you mentioned over here, they're gonna go live tomorrow. Tomorrow, Wednesday. So all these notes mentioned on this slide would add treatment diagnosis model in them. So you may see a little bit of difference when you try to write your notes. The treatment diagnosis model will be included to all the service documents.
And Rebecca, did you want to just take us through the billing cycle so supervisors and everyone can understand the obligations around our monitoring, which Elizabeth will talk about in a moment?
Yeah, I mean, we do. Hi, everyone. I'm Rebecca. Receive finance and as part of that, the billing for Medicaid and managed care. We do billing weekly, and the cycle it's pretty tight. So I know you all work really hard to get your notes in and make sure everything is signed and ready to go. Julie O'Dane, who oversees the billing for the clinic, she will run every Friday morning all of the claims that are coming up as failed. And that goes to the clinical supervisors weekly. The normal reasons, the reasons why claims are failing are generally because the notes are not yet signed or treatment plans are not in place for that date of service. And so that report gets sent around. And then I assume the supervisors are working with you all to make sure that all the documentation is in place so that we can then move forward with the billing. We run the billing every Monday, and we try to get it done so that it gets to Medicaid but before Wednesday. Anything that Medicaid receives on a Wednesday, it takes them then 3 weeks for them to process it. So it's constant sort of weekly cycle that we're going through this. And, you know, we have a limited amount of time that we can go back and bill for services. So we really try to have everything cleaned up and ready to go within 1 week of the date of service, if at all possible.
Yeah, and I just happy to, oh, Dr. Chandra, I think you have your hand raised.
Yeah, thank you, Rebecca. Just a basic
Sure.
question or comment for my nurse practitioners. What is the time limit for signing the note? One is regarding the billing cycle. On Friday morning, it will amount to false claim. By Monday, you must submit it.
Yeah.
But is it 24 hours? Is it 48 hours?
We would like them signed within 24 hours if that's at all possible. I know sometimes that is not possible, you know, but definitely within 1 week of having the service would be, you know, the last possible.
And so the Medicaid and Medicare regulation is as soon as possible after rendering services because people forget and it's not accurate. And as we saw that's one of the standards. And so generally, although Rebecca had mentioned a week, that's not a standard.
It should be within 24 hours.
It's within 24 hours, yeah.
Yeah, that was my understanding. It should be within 24 hours. Otherwise, we forget facts. The notes do not represent the exact clinical situation. So thank you.
I just want to turn back to the compliance program at Cases and the framework within which we are working on this issue. I mentioned the preventive audit that we did over the course of last summer and the issues that we were working to address. We will continue to provide training as part of. It is still billable, Olga. It's just opens us up to questions from OMIG, and I can talk a little bit about what that means and what the potential consequences are. So understand that things happen, but I agree with Rebecca and Dr. Chandra and Anne-Marie that 24 hours is ideal, is best, and that's what we're aiming for. So we will have training from Garfunkel health advisors who did the audit for us. Jack?
We have some questions, I think, from
Oh,
the
sure.
from the
Yeah,
big
there's some
group.
questions. Sorry about that.
Oh, yeah, so I can't see you all waving your arms.
I think it's
Yeah, I have a question. I
Orchid.
or comments. Okay, so I'm a nurse practitioner, and the 24-hour time frame is ideal. But when you're doing an IP and the patient is coming to the clinic for the first time with no other information, and you have to get collateral, sometimes 24 hours is not possible. So I just want to put it out there because patient come in, poor historian, you have to call the mom, you have to call another clinic, you have to call another facility that they are. Sometimes it takes them time to email this stuff to you, to call you back, things like that. So I just want to put it out there for people who.
Yeah, and to Olga's point, it's not that the bill becomes unbillable. It's that, and it sounds like you understand the urgency and you're working with a complicated situation. And I respect that. We all do. We understand that that's not always possible. So I appreciate that you understand the urgency and your, the documentation. If you're including all of that information as applicable, I think the note will tell the story of what you've done in that context.
So I have a question, sort of related, which I didn't know, but I met with Abigail and she actually walked me through it. If you're doing a 2-part intake, right? I don't know, Olu, maybe you can answer this question and provide information for other therapists. If you're doing a 2-part intake, what the process is and the documentation, meaning that you're meeting with the client more than once. There's a second scheduled appointment with this client and what the process is. I was not aware of that process, and I want to thank Abigail for coming in and walking me through it. I think there are other clinicians sitting here that don't know what that process is. Olu, are you there?
Yeah, I'm here. Yeah, so I did speak to Abigail to walk you through that process. Yeah, and I can have another meeting with all the other clinicians if we need to go over those documenting for 2 sessions. We can have a separate meeting on that. But did you understand the whole process after Abigail went through it, or do you need to go over?
Very thorough.
Say that again?
Yes, she was very thorough.
Oh, okay.
So
Okay.
Can you do another training for that?
Yeah, that's fine. We can schedule something. Thank you.
Any more questions on this end?
I have a question. Sorry. I don't know how to raise my hand on here. Is that okay?
So that's okay.
Yeah. I just wanted to go back to the when we were talking about medical complexity in terms of timing of appointments. I think just a comment is that it will be really important to capture the times because the complexity, I think, and this is my question, only comes if we're doing an E&M with a psychotherapy add-on as a psychiatric nurse practitioner, as in it is true. I'm asking, is it true that we have to do time because we are not, as nurse practitioners, providing that add-on psychotherapy?
I can try to take that one. My understanding from reading Medicaid regulations for psychiatrists, psychiatric nurse practitioners is that you must do time. Like time is just a standard that is required. And then depending on E&M codes, and I think we should come back to E&M codes, and it's probably its own session. It really depends on the complexity of issues that are being addressed within that session, but it sort of has to be timed. I'm not sure if I'm fully sort of answering the question, but I think clearly from this training, what's clear is that we want to ensure that we're providing more trainings sort of about the documentation. When we haven't gone to the standards and content of the documentation as well. This is just sort of the logistics that we're sort of covering today. And Dr. Chandra, you had a comment or question? Your hand was raised.
Yes, I have a comment. First of all, for IPE, I understand it takes more time, but that is the reason why after a lot of effort, we give extra 15 minutes after every 45 minutes of IPE. If you see the way the schedules are for me or any psychiatric nurse practitioner, you have 45 minutes of IPE followed by 15 minutes. And that should be completed during that time. That is the expectation. And that is what the E&M code refers to. For any complexities that you have undergone into that moment, you must document it in the plan or somewhere. As long as you have documented the extra things, it will count. And something that you do after the session, that goes to the memo to the chart. Instead of waiting for closing your document, keeping it open, it's better that you close the chart and add any accessory information into memo to the chart. So that's important. Now, my understanding of having 2 sessions for IPE, it will make you write 3 notes, and that Olu will discuss in a different session. But for each session, we can make sure to document every information the way it is, and then it will be billed appropriately. Thank you.
Thanks. Elizabeth, do you want to just take us through the compliance?
Yeah, sure. And the staff training, again, you know, if there are, we encourage you to ask questions if there are things that you think others would be. I know somebody made the suggestion about the 2 sessions and more training. Those are great suggestions. You can please continue to make them, because if you have a question, you're right, your colleagues probably do as well. So thank you for that. We will do another training with Garfunkel Health, as I mentioned, and cover some of the E&M and complexity, and like all of that is very complicated and changes from year to year on occasion. So it's important to have experts as a resource for answering some of these questions. So we appreciate your interest in that. We will, and we have been reviewing documentation. So for better or for worse, the start time and finish time is a very easy thing for me to check but via a report. And I think we are working to getting a dashboard by provider so that we can help give feedback in more real time. As Rebecca said, there's a tight timeline in this. And so I can look at what happened over the last month. That's not super helpful from a compliance perspective, because by that time things have already been billed. So if every appointment you've done started at 10:30 and ended at 11 or whatever the time, you know, whatever was on the schedule, it doesn't look good. If we were to be subjected to a random audit, that would be a question they would ask in the random sample and then carry it over to the broader, to the clinic more generally. So we would be open to a clawback of the fees that were paid, that Medicaid paid us for those services, because we didn't have our documentation in order. So the consequences are pretty significant, which is why we want to make sure we give you the information and the tools to be doing your part of this. And it's not because we're nitpicky and we want to make your life more difficult, because I know adding more steps into the process isn't everybody's best idea, but it really is because we have to. We are under a legal obligation as an organization, and if we don't work on these documentation standards, we are exposing cases as an organization to risks that we cannot tolerate in terms of our ability to function as an organization, as a nonprofit, serving the population we're serving under with the resources that we have. So as much as disciplinary action is not the best part to be talking about as a compliance officer, it's important that you know that given that we're providing this information and that it is a requirement that we have to be compliant with, that we expect you to be as well, and that there are consequences that leading all the way through the range of possibilities. And we will provide warnings and work with you, but this is not something that we can, as an employer, tolerate. So we look forward to getting this straightened out and moving forward in a way that best protects our ability to provide the services that you are providing. So it's not a disrespect of your time. It's not or your expertise. It's really how do we fit the compliance obligations into what we're doing now. So I appreciate the questions, and I'm sure there are more. I don't want to, we promised to be done by 10:30, but if there are more, so somebody's asking about standards and protocols, yes, we can absolutely work on that. And Garfunkel has promised those things as well. So this training is recorded, I think. So those of us who are not here will be provided that as well. You can use it as a resource. If there are specific, even having a little note card of the specific times that each session must be, whether it's half an hour, 45 minutes, would be a helpful thing. I agree. And we can work on those things.
And for everyone who is attending today's training, you're going to get a notice to go back into Cornerstone, and you're going to complete an attestation that you've completed the training and that you understand the standards by which documentation must be completed. And thank you, everyone. Sorry that we went over, and we do apologize for that. Looking forward to meeting you all again when we do some additional trainings. Take care, everyone. Enjoy the rest of your day. Bye-bye now. Thank you.
Bye.
Thank you very much.